A very good evening to all. So, I think you would have been listening to the lectures in your college. You would have been reading tons of pages from your Bailey and Love or SRB or your Manipal manual. So, may I know how many of you read Das textbook of surgery? Let me see. I just want an interactive session, guys. That's the main aim of this session. So what we are going to do, I'll tell you. We are not going to discuss the regular theory points. So causes, presentation, investigation, treatment of choice, the procedures, that and all you can read in your textbook itself. So what I am going to do majorly is I'm just going to tell you how to approach a pancreatitis case. Okay, so let me begin without further wasting your time and my time. So let us go into the discussion. So first, let's see a acute pancreatitis case. So let's forget it as a pancreatitis case itself. So we are going to get a patient. How the patient is going to come to us? The patient comes to us with a pain in epigastric region. The pain in the epigastric region, and the patient is also going to have peritonitis. The patient is also going to have peritonitis. What will be your approach? Can you tell me what will be your approach now? So the patient is coming to you with complaints of pain in the epigastric region, and there is a feature of peritonitis. How do you approach? What are the differentials you will have in your mind whenever you are going to get a pain in epigastric region and the feature of peritonitis? First, let me tell you what are the features of peritonitis. You have three features of peritonitis. Number one, on examination, you are going to see guarding, you're going to see rigidity, okay, rigidity, and you're going to see the third one, rebound tenderness. Rebound tenderness. Okay, so now the patient is coming to you with a pain in epigastric region, and you're going to do examination. In examination, you're finding guarding, you're going to find rigidity, and you're also going to have a rebound tenderness. Can you tell me what is the two differentials you will have in your mind? Come on, put it in the chat box. What are the two differentials you will have in your mind when I'm going to tell you that my patient is going to have pain in epigastric region and there is going to be a features of peritonitis? Just give your guess. Randomly, just give your guess. So there are only two causes can be there when the patient is going to present you with pain in epigastric region and when there is going to be features of peritonitis. Can you tell me what are the two causes? What are the two causes? Either it is going to be a peptic ulcer disease. Very good. Either it is going to be a peptic ulcer disease or it is going to be pancreatitis. Or it is going to be pancreatitis. But you know what? The patient is going to come to us with a pain. Acute pain is there. And there is a features of peritonitis. Now what you're going to do? You have to act shiftly, right? You're going to be in emergency room and you're going to see a patient in the emergency. So you have to start the treatment as soon as possible. So we have these two differentials. Either it is going to be peptic ulcer disease or it is going to be a pancreatitis. Let it either be there. So let it be a peptic ulcer disease or pancreatitis. The next approach which you are going to have is, without any further delay, put the patient on NPO. Whenever the patient is going to come to you with pain in epigastric region, and when the patient is going to have the features of peritonitis, without further delay, what you're going to do? You're going to put the patient in NPO. What is NPO? Nil per oral. You're not going to give any food for them. You're going to ask the patient to withdraw taking food by oral route. So you're going to stop the oral route feeding. Then you're going to start with IVF. So you're going to start with the IV fluids. And third thing is going to be IV antibiotics. And fourth one is going to be IV anti-inflammatory. What is this called as? So remember, in clinical conditions, anywhere if you're going to see a peritonitis, the first thing you're going to start is going to be antisepsis protocol. So this one, NPO, IVF, IV antibiotic, and anti-inflammatory. This four together, you call it as a sepsis protocol. So you're going to start this patient with a sepsis protocol. Why? Because there is a peritonitis, there is a chance of infection. So you're going to put the patient in sepsis protocol. You're going to start with very good Riles tube, Ari Prashant, excellent. So you're going to start with the Riles tube feeding. You're going to go with IV fluids. You're going to go for IV antibiotics. You can go for IV anti-inflammatory. But the thing is, than giving a Riles tube, I want to stop the complete food. Okay, I'm going to completely stop the oral intake of food. I'm going to prefer IV fluids, total parenteral nutrition I prefer rather than the oral intake. So, Riles tube is correct, But than Rails tube, you have to completely stop. Nil per oral is going to be the excellent answer, Risha Rajdurai. So now you have started with NPO. You have just given IV fluids, IV antibiotics, and anti-inflammatory. Next, what you're going to do? So in both these conditions, next you will be going for a chest X-ray. Next, you're going to go for a chest X-ray. Now, I have taken a chest X-ray. So, what will be my features of chest X-ray in case of peptic ulcer disease? And what is going to be my features in case of a pancreatitis? Anyone? Can you try? So, chest X-ray I have taken. So, it has to be either of the two. So, my chest X-ray, if it is going to be a peptic ulcer disease, what will be my features? And if it is going to be a pancreatitis, what is going to be my expected feature? Can you tell me in the chat box? So if it is going to be a peptic ulcer disease, what you will have, you will be having gas under diaphragm. You will be having gas under dome of diaphragm. Dome of diaphragm. Diaphragm. Okay, so that is going to be my features of X-ray in PUD. But now my case, I know that I am just checking out with pancreatitis because today's topic is going to be pancreatitis. So what I am going to do, I am going to see the X-ray features of pancreatitis. Can you tell me what is the X-ray features of pancreatitis? It is going to be exactly opposite to that of your peptic ulcer disease. In peptic ulcer disease, you add a gas under dome of diaphragm. Here, what do you have? Here, in your pancreatitis, you are going to have gasless abdomen. So what is the first feature? Gasless abdomen. Gasless abdomen. And what is the second feature you are going to have? You will be having a colon cut-off sign. You will be having colon cut-off sign. So first one is going to be a gasless abdomen and second one is going to be colon cut-off sign. Okay. So and third one is going to be sentinel loop. What is this sentinel loop? I hope that you all have your textbooks, guys. So you will be opening your textbook and keeping while I am discussing. So you can see the images from whichever textbook you follow. So X-ray image will be given in that textbook. And you can see that you will be having a sentinel loop. What is a sentinel loop? It is nothing but a focal dilated. It is nothing but a focal dilated proximal jejunal loop. Proximal jejunal loop in the left upper quadrant. In the left upper quadrant. So that is called as your sentinel loop. Okay. So now you have seen gasless abdomen. You have seen colon cutoff sign and you're going to see sentinel loop. So what will be the third thing you're going to do? Now I'm going to start with my, okay, now I have got a mind that this patient can be a pancreatitis patient. So what will be my clinical signs which I'm going to see in this case? So if it is going to be a pancreatitis, what are the signs I will be seeing? Can you tell me what are the signs? Number one, you can have something called as Cullen sign. Cullen, Cullen sign. I have to see whether my patient is going to have Cullen sign. And second thing I'm going to look for is Gray Turner sign. Gray Turner sign. Gray Turner sign. What is this Cullen sign and what is this Gray Turner sign? Both of them are going to be due to hemorrhagic pancreas. So if there is going to be a Cullen sign or if there is going to be a Gray Turner sign, that means that my patient is going to have a hemorrhagic pancreas. Hemorrhagic pancreas. These are the signs that are going to tell us that there is going to be hemorrhagic pancreas. So what happens in Culler's and Gray Turners? You will be having a blackish discoloration in your abdomen. You will be seeing a reddish or blackish discoloration over the abdomen. That is going to indicate Cullen sign or Gray Turner sign. Now what happens? Now I'm going to go for a serum lipase level. I'm going to check for serum lipase level. Then I'm going to check for serum amylase level. So I'm going to ask the patient to order for following investigation. So serum amylase and serum lipase. So these two are the pancreatic function test. Now I have taken serum lipase, serum amylase level. And it is going to be more than 3 to 5 times the normal value. It is going to be more than 3 to 5 times the normal value. So if it is going to be 3 to 5 times that of the normal value, okay, so what you're going to do, you're going to start with your treatment protocol. You're going to start with your treatment protocol. Similarly, now you understood that whenever the patient comes to you with a pain in epigastric region or when there is going to be peritonitis, what you're going to do, you're going to suspect for either peptic ulcer disease or pancreatitis. There is another presentation. What happens in another presentation? There will be a pain in the epigastric region. But now what I am telling is that pain is going to be radiating to the back. Now the question can be framed like this. They can tell you that there is a pain in the epigastric region and there is going to be a radiation to the back. In that case also, what you're going to do, you're going to start with the same, you're going to do same thing. You're going to go for a sepsis protocol. You will start with sepsis protocol, then you're going to take a X-ray, then you're going to take a X-ray, and after taking X-ray, what you will do, you will go for the serum lipase level. So there is going to be pancreatitis, there can be a suspect of pancreatitis, then you're going to go for the serum lipase and serum amylase level. Now the serum lipase and serum amylase level is going to be more than 3 to 5 times. It is going to be more than 3 to 5 times. Next, what you will do? Anyone? Next, what will be your next step? Can I know what will be your next step? When you're going to have serum lipase and serum amylase level raised more than 3 to 5 times, what will be your next step? You will go for will you go for a management? Will you go for another investigation, or will you start the treatment? Will you go for another investigation, or will you start the treatment? Many will think that, should you start a CT scan? Tell me, should you take a CT scan now? Should you take a CT scan now? Anyone? Let me see who's going to answer. Should you take a CT scan in this case? Should you take a CT scan in this case? Remember, so you should never start with CT scan immediately. You have to categorize the patient into whether the patient is having a mild symptom or whether the patient is going to have a severe symptom. Okay, you're going to classify whether the patient is having a mild symptom or whether the patient is going to have a severe symptom. Okay, whatever be it, what you will do is you are going to rule out the stones by doing an ultrasound examination. So next investigation, what you're going to perform is not CT. Many people will think that next you can directly go to CT, but remember, you're not going to go for CT scan. What you're going to do is you're going to first go for the USG, ultrasound. So you're going to do ultrasound. Why do you do ultrasound? To rule out stone. What stone? Gallstones. You're going to rule out the gallstones. You're going to rule out the gallstones. Similarly, in severe also, first you're going to do USG. You're going to rule out the gallstones. Okay, you're going to rule out the gallstones. Now, in the mild case, if you are going to, now you're going to categorize into two, whether stone is present or stone is absent. If the stone is present, you're going to go for lap cholecystectomy. You're going to go for lap cholecystectomy, and you're going to operate the patient and you're going to save the patient. Okay. If there is no stones, then find the inciting factors and you're going to stop the inciting factor. So this comes to the end of the mild condition. Now, coming to if it is going to be a severe condition. So there is a severe epigastric pain, there is a severe radiation to back, and you're having a sepsis, peritonitis is there. So now you have to continue the treatment. You have to actually manage the patient. Symptomatic management, supportive care has to be given to the patient. So you're going to put them in the admission. Now you are admitting the patient. Now you have ruled out the gallstone. Now you have to start with the supportive treatment. You're going to start with the supportive treatment. So what will be your supportive treatment? You're going to start with the central line. So I hope so you all know what is central line. Then you're going to start with a ventilatory support. NIV, mask. You're going to use NIV if required. Then you have to be ready for failure management. So if there is a heart failure, if there is going to be a liver failure, if there is going to be a kidney failure, so all the organ failures has to be managed because the patient is under sepsis. So under sepsis, the patient can go into organ failures. So you're going to try to manage organ failures. So now you are prepared for yourself for managing the organ failures. Then you're going to go for the nutrition. So what is the nutritional guidelines you're going to do? You're going to go for total parenteral nutrition. You're not going to put a Ryle's tube here, guys. Listen. So whenever you're going to have a severe pancreatitis, you're not going to go for Ryle's tube. Instead, what you're going to do, you're going to give total parenteral nutrition. Say, total parenteral nutrition. Okay, இந்த total parenteral nutrition கொடுக்குறீங்க. So, ஒருவேளை total parenteral nutrition கொடுத்து கொஞ்சம் சரியாச்சுன்னா, you can go for a Ryle's tube. you can also go for a Ryle's tube only if there is some improvement. If bowel sound is present, if the bowel sound is present, then you can go for Ryle's tube. So the condition here is, first you're going to start with total parenteral nutrition. When the bowel sound is present, you can go for a Ryle's tube feeding. You can go for a Ryle's tube feeding. Okay. So then comes the final one. So what you're going to do, you're going to do all these supportive care, and after 24 to 48 hours, you're going to manage this patient for 24 to 48 hours. After 24 to 48 hours, you're going to see whether the patient is improving or not improving. You're going to see whether the patient is improving or the patient is not improving. Not improving. If the patient is improving, you're going to continue this treatment. Continue this treatment for 6 to 7 days. You're going to continue this treatment for 6 to 7 days. Then what you're going to do is, you're going to take CT scan. So remember, only after 6 to 7 days of continuation of treatment, you're going to take a CT scan. Why do you take a CT scan? To rule out. What are the conditions you're going to rule out, guys? Can you tell me what are the conditions you're going to rule out here? You are going to rule out, number one, write it down, peripancreatic fluid. Peripancreatic fluid. You're going to rule out peripancreatic fluid, number one. Number two, you have to rule out the pseudocyst. You're going to rule out the pseudocyst, number two. Number three, you're going to rule out pancreatic abscess. You're going to rule out pancreatic abscess. Number four, you're going to rule out pseudoaneurysm. 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 Now, can you tell me which is the most common artery which undergoes pseudoaneurysm? Anyone? Can you put in the chat box? Which is the common artery which undergoes pseudoaneurysm? It is going to be your splenic artery. It is going to be your splenic artery. Clear, right? So now you are going to perform all these things to rule out the following. Now, if the patient is not improved, now what you're going to do, you're going to see whether gallstones is present. Again, you're going to do a USG to find out whether there is any gallstones present or if there is gallstone absent. Now, if there is a gallstone present, as usual, you can go for a endoscopic sphincterectomy. Endoscopic sphincterectomy. If gallstones are not present. Okay, if gallstones are not present, you're going to wait for 72 hours. After 72 hours of admission of patient, after 72 hours of admission of patient, what you're going to do is, you're going to take a CT scan. Now you're going to take a CT scan. Okay, so now I have taken a CT scan. So now after taking CT scan, what I'm going to do is, so after taking a CT scan, what I'm going to do is, I'm going to see whether any necrosis is present and whether any gas bubble is present. So whether any necrosis is present or whether any gas bubble is present. Gas bubble is present. Okay. Any necrosis is present or any gas bubble is present. Now the question, why do you take a CECT only after 72 hours? Because only after 72 hours, you can see a sensitivity. So sensitivity of CECT increases only after 72 hours. What is sensitivity? Finding the positive one. Finding the true positives. Sensitivity means finding true positives. You would have read in the community medicine. So finding true positive, finding a confirmation can be done only after 72 hours using a CT scan. Okay, so you have done by 72 hours after CT scan, you're going to find it that there is going to be either necrosis can be present or gas bubble can be present. Why do we need to rule out the presence of gallstone? See, you are going to rule out the presence of gallstone because the gallstones, it can actually obstruct the pancreatic duct, and that itself will incite the pancreatitis. So remember, the major cause, the most common cause of acute pancreatitis is going to be gallstone. Most common cause of acute pancreatitis is gallstone. That is the reason. Second most common cause, the alcohol. So first most common cause is gallstone. So now if you're going to find gallstone and if you're going to treat the gallstones, then you can automatically prevent or automatically treat the acute pancreatitis case. That is the reason why we actually rule out gallstones. To look for what are the other causes, or then only you're going to move for treatment because the management itself changes, right? So now moving on towards the CT scan. So it is going to be either necrosis you're going to do to find, or you can find some gas bubble. If it is going to be a necrosis, what you're going to do, you're going to do an aspiration. You're going to perform aspiration under, so you're going to perform aspiration under CT scan. Okay, then you're going to perform a culture and sensitivity. So aspirate panna fluid, culture and sensitivity test pandrenga. Okay, va? So then if it is going to be a gas bubble, so there is no need. So if it is going to be a gas bubble, then there is no need of culture and sensitivity. So, next step, can you tell me what will be your next step? What will be your next step of management? What will be your next step of management? Anyone? What will be your next step of management? Anyone? Let me see. Anyone can answer. So you're going to start with a specific antibiotic or high-end antibiotic that is going to be a meropenem. Meropenem is going to be the drug of choice here. So meropenem is going to be the drug of choice here. And if it is going to be severe pancreatitis, then what you can do is you can also go for a CT guided. You can go for a CT guided percutaneous retroperitoneal drain. Retroperitoneal drain can be kept. Okay, retroperitoneal drain can be kept. So how do you, what is the catheter used in the drainage? Can anyone tell me what is the drain? What is going to be the catheter used in the external drainages? In any external drainages, what is going to be the catheter used for drainage? Can you tell me? What is the catheter? It is going to be a pictile catheter. Very important. You have to remember. Anywhere in the body, if you're going to drain some infection, you're going to use a pictile catheter. You're going to use a pictile catheter. Clear, right? So now you're going to use pictile catheter, and even after using pictile catheter, it is going to fail. Then what you have to do? You have to remove the necrotic collections. Now you're going to remove the necrotic collection. Very good, Nidarshana. It's pictile catheter. So how we are going to remove the necrotic collections? You're going to do a surgical necrostomy. You're going to perform surgical necrostomy. Otherwise, there is also another technique that you can use, that is going to be your Baker's technique. Baker's technique. But you remember, Baker's technique has a high mortality. Therefore, we are not performing nowadays Baker's technique. So surgical necrostomy we are going to perform. Along with that, you can go for a feeding jejunostomy. I thought that you will be asking me this question, guys. So I classified this as severe. There should be some guidelines to classify any case as severe, mild, dysentery. You should have asked me in the chat box, right? So why, sir, you classified a case as severe pancreatitis? So there must be some important criteria which is given that differentiates your mild pancreatitis from severe pancreatitis. Which is going to differentiate the mild pancreatitis and severe pancreatitis? That is called as your Ranson's criteria. So write it down. So the one that differentiates your severe pancreatitis and mild pancreatitis is going to be your Ranson's criteria. So what is this Ranson's criteria? Remember, so we have to classify on admission. Okay, you have to classify on admission first, and you also have to classify within 48 hours. Isn't it? So just go back to the protocol and see. So on admission, you're going to classify it as mild and severe. And after 48 hours, you have to classify whether the patient is improving or not improving. So we have two criteria. On admission, there is a Ranson's criteria. And after 48 hours, again, you're going to investigate. Again, you're going to see the Ranson's criteria. So on admission, when do you call it as a severe? When do you call it as a severe? When the age is going to be more than 55 years. When WBC count is going to be more. So I don't want to go into the values and all. So it is actually WBC more than 16,000 per microliter, but I'm not much interested in say WBC count and all. I'm just telling that there is a much increase in WBC count. Remember like that. And then the third one is going to be when there is going to be a blood glucose level very much high. That is more than 200 gram mg per deciliter. Then I'm going to have an increase in the AST level. I am going to have an increase in the LDH level. So LDH is more than 350 and your AST more than 250. So WBC more than 16,000, age more than 55, glucose more than 200, AST more than 250 international unit per liter, and LDH more than 350 international unit per liter. So this is going to tell me that my patient is going to be severe. Then within 48 hours, so I'm going to admit my patient, I'm going to start all my supportive treatment. After starting my supportive treatment, after giving a total parenteral nutrition, after 48 hours, I'm going to classify them whether my patient is improving or not improving. When will I call my patient is not improving? I'm going to call that my patient is not improving when the hematocrit value is decreased by 10%. Hematocrit value which is taken on admission, and when you're going to compare with now within 48 hours when you're going to take, then the hematocrit value is less than 10%. decrease of the hematocrit is going to be more than 10%. Or when your blood urea nitrogen level is going to be raised, blood urea nitrogen is more than 5 mg per deciliter, or when the serum calcium level, is going to decrease, or when the serum calcium level decreases, that is less than 8 mg per deciliter, or when the PaO2, so oxygen saturation, that is also going to decrease. It has come down to 60 millimeter of mercury. And when the base deficit is going to be increased, base deficit is going to be more than 4 milliequivalent per liter, and the need of fluids is going to rise, then you're going to consider this patient as severe. So now repeat along with me. Just see here, hematocrit is going to be decreasing, serum calcium level is decreasing, oxygen saturation decreasing. And what are the one that is increases? Your blood urea nitrogen level increases. You're going to have an increase in your base deficit. You're going to have increase in the need of fluid. So automatically when the blood urea nitrogen is going to increase, your base deficit will also increase. Okay. So the need of fluid is also going to be raised. So this is what called as your Ranson's criteria. So remember, what you have to remember in Ranson's criteria, when the score is less than 3, so your mortality is going to be decreased. Your mortality is going to be decreased 0 to 3% only. When it is going to be 3 to 5, then your mortality is going to be around 11 to 15%. When it is going to be more than or equal to 6, then your mortality is going to be more than 40% mortality. And that is going to be your severity scoring Ranson's criteria. Now you know Ranson's criteria, but your book will be giving more criteria. What are the other criteria you're going to see in your textbook? One is going to be a Glasgow criteria. So remember, Glasgow criteria is valid only when gallstone alcohol-induced pancreatitis. Okay, ma? So Ranson score is only for alcohol-induced pancreatitis. Ranson score is only for alcohol-induced pancreatitis, whereas your first most common cause is going to be your stone. So when you're going to have stone induced, or it is going to be stone induced, or it is going to be gallstone induced, or when it is going to be alcohol induced. So for both the things, if you're going to have, then you're going to go for the criteria called as Glasgow criteria. So Glasgow criteria is the one we are going to use. What is the other Glasgow you have? So two more Glasgow you're going to see in your surgery. One is going to be your Glasgow coma scale. And second is going to be a Glasgow outcome scale. So Glasgow outcome scale you use in the brain death patient. Outcome, brain death patient. You'll calculate பண்ணுவீங்க. Glasgow coma scale is going to be used for calculating the consciousness, alertness. Then you're going to classify whether the patient is going to be very sick or the patient or a severity. Index பண்றதுக்காக. Next, coming to a neurological அவங்களோட ஸ்டேட்டை கண்டுபிடிக்கிறதுக்கு Glasgow coma scale யூஸ் பண்றோம். Now coming to the Glasgow criteria is used to grade the severity of pancreatitis when it is going to be having a gallstone induced as well as alcohol induced. So இதுல நீங்க full criteria படிக்காதீங்க. What you have to remember is when it is going to be more than equal to 3, that indicates severe pancreatitis. Okay, and another scoring system you have, that scoring system is called as Balthazar grade. Balthazar grade, again, this, please don't read what all the points and all. Here, what you have to know is Balthazar grading is going to be a CT severity index. It is CT severity index, and more than or equal to 6 indicates severe pancreatitis. Severe pancreatitis. Okay, this is Balthazar grade. So you now know Ranson's criteria. Ranson's criteria you have to read fully. Glasgow criteria is there, and third is going to be your Balthazar grading. Okay, next you are going to have is a Atlanta classification. Atlanta classification. What is this Atlanta classification? So you're going to grade it as mild, moderate, severe. You're going to grade your pancreatitis into mild, moderate, severe. When do you call it as a mild? So when there is no local complication, when there is no organ dysfunction. Okay, local complication, organ dysfunction. ரெண்டுமே இல்லனா, you call it as mild. When you're going to have a local complication but no organ dysfunction, you call it as moderate. And when both are present, you're going to call it as severe. This is all about the Atlanta classification. Now, can you tell me what are the causes of acute pancreatitis? Now, let's go back. What are the causes of acute pancreatitis? Remember, causes of acute pancreatitis. Causes of acute pancreatitis. Remember, most common cause is going to be your gallstones. Most common cause is going to be gallstones. Second most common cause is going to be alcohol. Second most common cause is going to be alcohol. Remember, second most common is going to be alcohol. And third most common is going to be trauma. And trauma is most common cause in children. Most common cause in children. And fourth is going to be drugs like your ART therapy, chemotherapy, thiazide diuretics. All this can cause acute pancreatitis. And hyperlipidemia. Hyperlipidemia, and scorpion bite. Even scorpion bite can cause bite. Scorpion bite. And then seventh one is going to be hyperthyroidism. Hyperthyroidism. Okay. So these are going to be the causes of acute pancreatitis. Clear, right? So now you told various others complications, right? Peripancreatic fluid, pseudocyst, pancreatic abscess can be there, splenic artery can be there. So what is going to be out of all these Ranson's criteria, which one is going to be most sensitive prognostic factor? Remember, most sensitive prognostic factor, because after 48 hours, I'm going to look for whether there is any improvement or not. Which one is going to tell me exactly whether my patient is going to have an improvement or no improvement? So excellent prognostic factor is going to be your, what is that? Anyone? Any guess? Hematocrit. So hematocrit is going to be the most sensitive prognostic factor. So now my patient is going to have a, for example, after 48 hours, I'm looking. My patient is going to have peripancreatic collection. What I'm going to do? If my patient is going to have a peripancreatic collection, so then what I'm going to do is I'm going to put a pigtail catheter and drain it. If my patient is going to have acute necrotic collections, necrosis is there, then I'm going to go for a pigtail catheter followed by necrostomy, surgical necrostomy. If my patient is going to have a pseudocyst, what will I do? If my patient is going to have a pseudocyst, what will be my management? Pseudocyst இருந்ததுன்னா, okay, if my patient is going to have pseudocyst, remember, they will undergo spontaneous resolution. Okay, they may cause GOO. So they may cause GOO or extra hepatic obstruction, extra hepatic biliary obstruction. If there is going to be extra hepatic biliary obstruction or GOO, just wait, because they can spontaneously resolve. You are going to just wait and observe. Wait and observe. Okay, if there is no big symptoms or Ranson's criteria is not going to be matching for a severity, then you're going to wait and observe. If you're going to have a cyst more than 6 centimeter or 6 weeks resolve agala. Okay, 6 weeks not resolved. Or if the patient is going to have complication, then you're going to go for an internal drainage, internal endoscopic drainage, internal endoscopic drainage. Clear? So this is what we are going to do if there is going to be a pseudocyst. Okay, if there is going to be a pseudocyst, this is what we are going to do. If there is going to be a walled off necrosis, then you have to do an external drainage. If the patient is going to have splenic vein thrombosis, then you're going to treat accordingly. Left-sided pleural effusion, you're going to treat accordingly. That's all. This is all about your acute pancreatitis. Any doubt in the acute pancreatitis, guys? Any doubt in the acute pancreatitis, kindly respond in the chat box. We will be moving towards the chronic pancreatitis. That's all. How easy it is. Can you see how easy it is? How we made it very, very easy. Can you just tell me in the chat box? This is how you are going to read your surgery. You're not going to put too much efforts. You're going to just put very small nominal effort that you can actually crack your exam very well. This is all about how to read your pancreatitis. Any doubt? Shall we move towards the next one? Can you guys respond in the chat box? Shall we move towards the next one? So next we are going to move towards a chronic pancreatitis. Chronic pancreatitis. Just kindly respond in the chat box. Please give a cheers. Okay, just encourage yourselves to be active in the session, because only if you're going to remember things. Okay, so now we are going to move towards chronic pancreatitis. If you have any difficulty in understanding or in the methodology of learning, which we are just doing right now, you can just put it in the chat box. I'll be very happy to respond to you guys. So now moving towards a chronic pancreatitis. What is a chronic pancreatitis? What will be the causes of chronic pancreatitis? So now we are going to talk about chronic pancreatitis. So causes of panic pancreatitis, you're going to just remember Tiger O. You're going to just remember Tigar O. T stands for toxins, especially your alcohol. I stands for idiopathic. I stands for idiopathic. G stands for genetic. G stands for genetic. A stands for autoimmune. Autoimmune. And R stands for recurrent. Recurrent means due to stones. Okay. And O stands for obstruction. I told you, right? So if at all the patient is going to have obstruction here, so if there is going to be any extrahepatic obstruction or if there is going to be any complication, that can actually lead us to, chronic pancreatitis. So if it is going to be a chronic pancreatitis, how the patient will be presenting to you? The patient will be presenting to you with same complaints, but additionally what you're going to have, you're also going to look for, because here when it is going to be going for chronic, that means that the patient is going to have a stone formation. There may be stones, there may be a toxin, there may be autoimmune reaction. So how you are going to present is the patient will be presenting with pain in epigastric region. Pain in epigastric region. So patient will be definitely an alcoholic patient, and the patient will be presenting with obstipation. Obstipation means obstruction of your intestine. Obstipation. So when the patient presents to you like this, then you're going to immediately see serum lipase level and you're going to see serum amylase level. Definitely serum amylase and serum lipase will be increased, that is for sure. So when the patient is going to have increased serum lipase and serum amylase level, so when it is going to be increased, next investigation, what you're going to do is investigation of choices, MRCP with excretin, okay, MRCP with secretin stimulation. You're going to perform MRCP with secretin stimulation. Now you're going to perform MRCP with secretin stimulation. After performing a MRCP with secretin stimulation, what is going to be your next step? You're going to go for ERCP. So ERCP is going to be the gold standard. Whereas investigation of choice in ketangana, it is going to be MRCP with secretin stimulation. Now you are going to take a MRCP with secretin stimulation. You're going to next perform ERCP. When you perform ERCP, what is going to be your appearance? You're going to get a chain of lake appearance. You're going to see a chain of lake appearance. So in ERCP, you're going to find a chain of lake appearance. When you're going to find a chain of lake appearance, what will be your next step? When you're going to find a chain of lake appearance, your next step is we are going to diagnose it. Now we are going to manage this patient. How we are going to manage this patient? First thing is you are going to have a pancreatic insufficiency. That is for sure. The patient will be having a pancreatic insufficiency. So there will be a reduced insulin secretions. So you have to manage with insulin and oral hyperglycemic drugs. Okay. Then pancreatic enzyme is decreased. So the patient will be having a malabsorption. So you can actually go for a fecal fat analysis. So in that case, what you can do, you can go for an exogenous enzyme replacement. So now I have replaced my insulin for endocrine function. I have replaced my exogenous enzyme for the exocrine function. Now I have to treat the actual cause. How do you treat the actual cause? You will start with analgesics. Analgesics. So I'm going to give analgesics till the time of patient is responding. So you have to give this till the patient responding. Okay. So now I'm going to see whether the patient is responding or not. Responding or not. Responding or not. So if my patient is responding, there is no intervention needed. No intervention needed. I'm just going to continue. Okay. I'm going to continue. Okay, wow. So I'm going to continue. If the patient is not responding, again I have to just continue with analgesic. So again I have to continue with analgesics. Analgesics. I have to continue with analgesic till it is responding. If the patient is going to stop responding at one point of time, stop responding at one point of time, or if the patient is not responding at all, then you're going to go for surgery. So in this case, now you're going to start with surgical intervention. What will be your surgical intervention? So you have to do two things, guys. First, you have to start with drainage. Why you're going to do drainage? Because the patient is going to have a block in the pancreatic duct. So there is going to be a பிளாக் ஸ்டோன்ஸா இருக்கலாம், இல்லை எனி ரீசனா இருக்கலாம், பிளாக்டா இருக்கு. நம்ம என்ன பண்ணணும்? ட்ரைனேஜ் பண்ணணும் ஃபர்ஸ்ட். ஸோ ஹவு டு யூ ட்ரெயின் இட்? ஸோ யூ கோயிங் டு செக் ஃபார் த டயாமீட்டர் ஆஃப் மெயின் pancreatic duct. Check for the diameter of main pancreatic duct. If the diameter of main pancreatic duct is going to be less than 5 millimeter, you go for ERCP. You go for ERCP plus sphincterectomy. Sphincterectomy. Okay. If it is going to be more than 5 millimeter, if it is going to be more than 5 millimeter, what will be your treatment of choice? You go for the, anyone? Anyone, can you tell me what will be your treatment of choice? When it is going to be more than 5 millimeter, what will be your treatment of choice? Anyone? Can you tell me? What will be your treatment of choice? You go for a longitudinal pancreatic jejunostomy. So you go for jejunostomy. You go for a longitudinal pancreatic jejunostomy. So this is otherwise called as Puke-Stowe. So this is otherwise called as Puke-Stowe. Remember, this is otherwise called as Puke-Stowe's procedure. Okay. If the patient is going to be, so now you have just drained it. So now the patient is not responding. Okay, the patient is not at all responding. So you have to, if you're going to, if that infection or pancreatitis is just restricted, it is just restricted to the tail. Okay, then you're going to perform a distal pancreatectomy. Or if the thing is going to be present in head and neck also, then you're going to do a beggar's procedure. What is beggar's procedure? Duodenal preserving pancreatic head resection. You're going to perform a duodenum preserving pancreatic head resection. You're going to perform. Okay, so this is how you're going to treat a patient, or you're going to treat a patient with pancreatitis. Is it clear, guys? This is how you're going to treat the patient with pancreatitis. So this is going to, Puke-Stowe is going to be a, whether it is going to be end to side or side to side. Yes, this is going to be side to side anastomosis. If it is going to be end to end anastomosis, then it is going to be Duval's procedure. It is called as Duval's procedure. Okay, so now you know what is Puke-Stowe's procedure, what is Duval's procedure. So this is all about your pancreatitis, guys. Okay, I'll just revise once again before closing this session. Okay, so pancreatitis. So you're going to check whether it is going to be acute or chronic pancreatitis. So first, you're going to see whether there is any pain in the patient in epigastric region. Peritonitis is there. So when there is a peritonitis and pain in epigastric region, or when there is going to be a pain radiating to the back, you're going to go for the sepsis protocol, irrespective of your diagnosis. Let it be your PUD, let it be your pancreatitis. You're going to start with the sepsis protocol. What is a sepsis protocol? NPO, IVF, IV antibiotic, IV anti-inflammatory. Then you're going to take a chest X-ray. Sorry, and your abdomen X-ray, erect abdomen X-ray. So in your PUD, you will have a gas under dome of diaphragm. In pancreatitis, you will have a gasless abdomen. You will have a colon cutoff sign. You will have a sentinel loop. When you're going to have all these features, so you're now going to confirm that my patient is going to have a pancreatitis. Now I'm going to look for the signs. What are the signs I'm going to look for? Cullen sign, Gray Turner sign. What is this going to indicate you? Hemorrhagic pancreas. Next, what you're going to perform? You're going to perform serum lipase, serum amylase test. So serum lipase, serum amylase test is performed, and you're going to start with that treatment. So what is the treatment? So before starting with treatment, you have to differentiate whether my case is going to be a mild case or severe case. How do you do that? By doing a Ranson's criteria. What is Ranson's criteria? On admission, age more than 55 years, WBC is high, blood glucose is high, AST is high, and LDH is high. In that case, I'm going to classify it as severe. Now, after classifying it as severe, what I'm going to do? I'm going to perform a USG. Why do I perform a USG? To rule out gallstone. As Hari Prashant asked, why you have to rule out gallstone? Because gallstone is the most common cause. If it is a gallstone, you can just perform a laparoscopic cholecystectomy and you're going to save the patient. If it is not going to be the cause, if gallstone is not going to be the cause, you have to stop the inciting factor. If it is a mild or if it is a severe, you're going to start with a supportive treatment. What is my supportive treatment? Central line I'm going to start. ventilatory support I'm going to start. Failure management I have to perform, and nutrition is total parental nutrition, and I'm going to maintain the case for 24 to 48 hours. After 24 to 48 hours, I'm going to see whether my patient is improving or not improving. If it is improving, continue for 6 to 7 days. After 6 to 7 days, I'm going to do a CT scan. Why do I do CT scan? To rule out peripancreatic fluid, pseudocyst, pancreatic abscess, and pseudoaneurysm. Pseudoaneurysm, the most common artery is going to be a splenic artery. Now, it is not improving. You're going to see the hematocrit value. It is going to be decreased more than 10%. And your blood urea nitrogen is increased. You're going to have your base deficit increased. You're going to have need of fluid increased. And serum calcium and your oxygen saturation is going to be decreased. In that case, my patient is going to be not improving. Now, I'm going to see whether gallstone is there or not. If gallstone is there, I'm going to perform endoscopic sphincterectomy. If that is not there, after 72 hours, I'm going to do a CT scan. Why do I do a 72 hours Capra CT scan? Because it is going to improve our increased sensitivity. Now, I'm going to see whether there is any necrosis or gas bubble. If there is any necrosis, I'm going to do a USG guided aspiration, CT guided aspiration. I'm going to perform a culture and sensitivity test. If there is a gas bubble, I'm not going to do anything. I'm going to start with my treatment. What is going to be my treatment? Antibiotic. What antibiotic? Meropenem. After meropenem, I'm going to perform a CT guided percutaneous retroperitoneal drain. What is the drain I'm going to keep? Pigtail catheter. After that, what I'm going to do? I'm going to see the patient, observe the patient. If my treatment has failed, then I'm going to perform a surgical necrostomy. Why do I perform surgical necrostomy? Because my patient is going to have necrotic areas are going to be there. I want to remove it. We can also do a beggar's technique. But what is the problem with beggar's technique? It has an increased mortality. So, and also I'm going to perform a feeding jejunostomy. So now, if my patient is going to have a pseudocyst, what I'm going to do? I'm going to perform a spontaneous resolution. I'm going to check, wait and observe. If there is going to be extrahepatic obstruction, if there is going to be gastric outlet obstruction, if the obstruction is going to be more than 6 centimeter, my cyst is more than 6 centimeter, or if after 6 weeks also there is no resolution, or there is going to be a complication, I'm going to perform internal endoscopic drainage. Okay, clear. Now, I'm going to have different criteria. We have already saw Ronson's criteria. There can also be a Glasgow criteria. There can also be Balthazar grading. There can also be Atlanta classes. Clear, right? Most sensitive prognostic factor is hematocrit. Now, chronic pancreatitis. What are the causes? TIGARO. T stands for toxin. I stands for idiopathic. G stands for genetic. A stands for autoimmune. R stands for recurrent. O stands for obstruction. Whenever the patient comes to you with a pain in epigastric region, alcoholic, obstipation characteristics are there, you're going to perform a serum lipase, serum amylase. So what is going to be my investigation of choice? MRCP with secretin stimulation. So what is going to be my gold standard test? ERCP. In ERCP, what I'm going to see? Chain of lake appearance. I'm going to perform my treatment. What is my treatment? First, I'm going to start with analgesic. Why do you give analgesic? To stop the pain. Now, I'm going to see whether there is going to be improvement in the patient or the patient is responding. If the patient is not responding, again, you're going to give analgesic. Again and again, you're going to give analgesic till the patient is not responding. If the patient has stopped responding or if the patient is not responding, then you're going to start with surgery. What is going to be my surgery? I'm going to perform drainage. So what is the drainage? I'm going to see the diameter of main pancreatic duct. If it is going to be less than 5 millimeter, I perform ERCP with sphincterectomy. If it is more than 5 millimeter, longitudinal pancreatic jejunostomy, that is called as puke stove, side to side anastomosis. End-to-end anastomosis, I call it as Duval's procedure. If the patient's pancreatitis is restricted only to the tail, I do distal pancreatectomy. If it is going to involve head and neck, I perform beggar surgery, duodenal preserving pancreatic head resection. Preserving pancreatic head resection. With this, we are completing the pancreatitis. A very short and brief discussion I did. So this is the symptomatic approach, syndromic approach. This is how you have to learn, guys. When you're going to learn like this, you know what is the symptoms, what is the signs, you know how to treat the patient, what is the investigation you need to take, what are the features of the patient, what is the cause of the disease, everything you can understand. So as simple as that. So very easily we have completed the acute and chronic pancreatitis. If you have any doubt, you can just put it in the chat box or in the group. If you want more session like this, do message me in the group so that I'll prepare. If you need any specific topic like this also, we can prepare. So short sessions are what I have just planned for you for the next couple of weeks. So you can put every every day we will discuss some short topics in surgery or in medicine or OBG or pediatrics. Whatever you need, just put it in the chat box or put it in the group. We will just try to discuss. Okay. Thank you so much. Have a great night. So please revise it and go to your bed. Okay. Thank you. Good night.